Isn't it?
This is really
Okay.
good. Very good.
Okay. Time to mute.
I think people will be joining in
Yeah.
soon. But we can't start.
Can you hear me, Kanta?
Yes, I can. I can hear you.
Okay, fine. It's almost done. Everyone muted? Kara, ready?
Ready.
Uh,
Yeah, everyone's muted.
Please make sure everyone is muted, yeah? 1, 2, 3, go. Good morning, good afternoon, good evening, wherever you are in the world. Welcome to Meet Menaca to celebrate you. Today, we have a really special guest, Dr. Sandeep Gupta, who's a senior consultant cardiologist, to speak about Heart Disease 2021, who, why, and when. So before we go into asking questions and diving deep into what we are going to speak about today, let me introduce today's speaker. Dr. Sandeep Gupta, as I said, he is a consultant cardiologist at Whipps Cross at St. Bartholomew's Hospital. Dr. Gupta was awarded a BHF Research Fellowship to explore the relationship between inflammation and heart disease. Over the last 15-20 years, Dr. Gupta has also remained passionate about dedicating his free time to raising awareness of heart disease, in particular in South Asian communities. To do so, he has worked with major communities, acting as a chairman of the BHF strategy group and cardiovascular health and ethnicity, and a member of BHF and profession and care committee. If we have to tell all his credibilities today, we will be just spending the time doing that. So without further ado, let me introduce our special speaker today, Dr. Sandeep Gupta, to tell a few words about himself. Over to you, Sandeep.
Thank you very much, Menaca, for the invitation, and lovely to see everyone in this meant to be a restful weekend for everyone. So it's interesting that you still managed to get a few people to join in. So as Menaca said, I'm a consultant cardiologist. I've been based in London, Whipps Cross and St. Bartholomew's Hospitals. I've been a consultant since 1999. And one of the beauties of our speciality is that we do so many different things. We do ward rounds, clinics, we do procedures, emergencies, and even in the hospital itself, we're often doing a safari, looking at heart patients all over the hospital as well. And in my free time, I've always enjoyed doing charitable stuff, lecturing on heart disease in temples and churches and mosques, working with the Olympics Committee, British Heart Foundation, and been privileged to have lectured around the world as well, different societies and congresses. So it's a pleasure to be here.
Thank you, Sandy. To be precise, the last I read, it was 70 countries. So it's not a small number of countries you have spoken in. So I'm really honored and privileged to have you as a guest speaker today on our platform. So just to start, to give a perspective of how this heart disease is prevalent, how big a problem is it in the UK?
Yeah, so when we talk about heart disease, we must remember one thing. The heart is quite complex. You've got the heart pump, you've got the valves, you've got the arteries, you've got the electrics, you've got the sac. And all of those bits can go wrong. But the number one disease related to the heart is what we call coronary artery or coronary heart disease. And that's the focus, because that is the biggest killer, not just in the UK, but in the Indian subcontinent and globally as well. Now, just to give you a perspective, probably today, 3rd of April, about 150,000 people will die in the world at midnight, by midnight, and of which 50,000 are from cardiovascular disease. And if you look at COVID, for example, maybe today in the world, tragically 7 or 8,000 may die. And obviously we'll come back to the link with coronavirus and cardiovascular disease. And then if we look at the UK as well, the two big killers are cancer and cardiovascular disease. And for example, the British Heart Foundation have calculated maybe every 3 minutes in the UK, someone has a heart attack. And not all of them will sadly die, but that's just presenting with a heart attack. So maybe 200 events a day.
Sure, that is a really scary figure to address. So I know you mainly worked in East London for many decades, perhaps a couple of decades now. So can you give us a picture of heart disease in East London, Dr. Gupta?
Yes, so as with any part of the UK, there's almost like a east-west divide or a north-south divide. We know that even in the UK, there is a north-south divide, meaning house prices, how nice people are, poverty, but also death rate. And if you go to places like Manchester, Newcastle, Glasgow, they are real death spots for heart disease compared to the wealthy Berkshire, Surrey, and West Sussex, etc. So there's a north-south divide almost. And within London as well, there are differences, there are disparities. And in East London, we have some of the highest death rates in the whole of the city as well. And there's a famous picture of the tube line, the Jubilee line. And if you go by the underground from Westminster, Jubilee line to Eastwards, up to Stratford and beyond, for every one stop, you lose 1 year of your life. And that's related to the gradient of heart disease within London. And then back to our area where I work in practice, Tower Hamlets, Waltham Forest, Redbridge, often the death rate from heart disease is 5 to 10 times greater than, say, Bromley, Westminster, Richmond, wealthier areas. And a lot of that is to do with social class, not just ethnicity, but another factor is big immigrant populations with higher cardiovascular rates. Yeah.
Sure. Thank you. I mean, when you explained the Jubilee line, I definitely made me sit up and listen because I almost live in the other end of the Jubilee line. So, near Stanmore, Edgware. So it's really interesting how this geography actually pans out. It's, definitely insightful to know that. So, we know now the coronary heart disease is one of the main killers in generally in the UK and particularly in the Asian population. It's been talked about a lot. So why do people get coronary heart disease in your opinion as an expert?
Yeah, so that's a good question. So if you look at people presenting with angina, with heart attacks and sudden cardiac death, the main issues. And there is often a balance between genetics, you have a family history and you have the wrong genes, and also environment. Now, if we say, largely speaking, you can't do much about your genetics and family history, but there's things in the environment that we can look at: cigarette smoking, obesity, diet, exercise, and then we move on to things like hypertension, high cholesterol. So all of these things are in the mix in terms of who is going to get have a coronary event, who is more at risk. And some things can protect you, like regular physical activity, keeping your weight down, keeping your blood pressure controlled, your sugar controlled, cholesterol. But there's other things that we can all recognize we need to do a little bit more work towards. And then you have the ethnicity angle. Now, if we look at Africans and Caribbeans, they tend to get more diabetes, hypertension, and stroke. Whereas the South Asian community, Indians, Pakistanis, Bangladeshi, Sri Lankans, that population, South Asians, tend to get more coronary artery disease. And we can touch on all the risk factors if you want, Menaca.
Sure. Okay. Of course. I just wanted to know, why they get in the, first place. Thank you so much for that explanation. So what are the risk factors? So, we as general public or even as professionals, we mostly know it could be smoking or obesity or diabetes or blood pressure or diet,
Yeah.
but it is a very superficial knowledge we have. So as an expert, what would you tell are the risk factors?
Right. So one of the most important risk factors, which is preventable globally, let's move away from East London, UK to the global, is cigarette smoking. And as we know, it's not just cigarettes, it's e-cigarettes, it's shisha, it's chewing tobacco. So all of those things have the same kinds of ingredients. And if you look at cigarettes, for example, one cigarette may have, 2,000 chemicals, and 60 of them are direct causes for cancer, carcinogenics. And they say, and this is something that everyone will always remember, that for every one cigarette you smoke, you will lose 11 minutes of your life. And every time I say that, I see people adding up, how long have I got left? But the point about cigarette smoking and cardiovascular disease is that if you look at heart attack in Colombo, Taipei, Johannesburg, or Manchester, the first heart attack can be explained sometimes by almost 40% higher rates of cigarette smoking. So it's a very important risk factor. But the thing that we want to move towards is what we call smoking cessation. That yes, fine, people do become addicted or pick up the habit. We need strategies amongst our health colleagues, health professionals, to help people quit as well. And the reason is that if you stop smoking, let's say for 1 year, ex-smoker, you will already halve your death rate from heart disease. And if you stop smoking, say for 15 years, you're like a non-smoker for heart disease. And if you stop smoking for 10 years, you're like a lung cancer patient as a non-smoker. So I think one bit is to tell people of the harm, but also to give them strategies to help quit. And these are things like Champix or nicotine patches, or we've got in the UK, in our health service, we have smoking cessation officers as well. So cigarettes is important. Then if we come on to, let's say, a bit more relevant to the South Asian community, is diabetes. Now, for example, in the UK, white British Caucasian population, maybe 5% diabetes. But for the South Asians, up to 20, 30%. And the point about diabetes is that on the day you are diagnosed diabetic, you double your risk for cardiovascular disease. And often diabetes is brewing unrecognized, what we call pre-diabetes. And usually people have had diabetes brewing for 5 years before we diagnose. And so they've had problems already developing. So I think it's a very important thing. And what people need to link diabetes with is obesity. And what happens in particular in the South Asian community, there's no point weighing South Asians. It's not really the relevance of BMI, it's waist circumference. So you get a tape measure out. And what we find is that central obesity around the waist, which we can all feel and recognize, that is more of a potent risk factor for diabetes, and especially in our community. And then, overlapping is this big pandemic. There's lots of pandemics, but another more important one at the moment is obesity. And we know that with fast foods and sugary drinks, and they say 30% of school kids are overweight. And if you look at Corona, especially in the first wave, we saw a clear risk factor. People who were more likely to end up on intensive care or die from coronavirus were those with other risk factors, including heart disease and obesity. Clear link. And linked to that is diabetes. We'll talk about diet. Should I just carry on exploring these risk factors?
Of course, I can't wait to hear. Yes.
Okay. So if we look at another issue, which is high blood pressure, hypertension, and if we, the world's population is around 7 billion people, this, in terms of population, they say over 1.2 billion have high blood pressure. And it's probably the world's #1 risk factor in terms of numbers. And we know that if you don't control your blood pressure, you increase your kidney problems risk, your stroke risk, and Dr. Naranja will know, and also cardiovascular coronary rates. And what we've learned now is lower is better. It's a famous conclusion in heart disease, lower is better. And there's now evidence that whilst we used to say maybe 140 over 85 is fine, we're now seeing evidence that if you can go to 120 over 75, the event rate is even lower. And this is usually because you need appropriate medication as well. If we look at why people develop hypertension, it's an aging thing. So when you reach, say, age 70, 70% have hypertension. And if we can address it earlier, we could reduce events later. In terms of what people can do, the public can do earlier, is to be careful not only in weight and getting obese and linking that with hypertension, but also salt intake. And one thing that patients and public may not be aware of as much is that we need to look at our food diary and aim for less than 6 grams of salt a day. Now, it's not so much the added salt, it's the hidden stuff. Cheeses, tin foods, pickles, all the favorites. And what people need to do is try and tweak looking at their salt intake, and that can help prevent a tablet for hypertension. So that's one thing that we try and push for.
Sure.
And I suppose, we can now go into diet as well. I mean, I'm not a dietitian, but we know that those patients who have a high calorie intake, saturated fat, and the carbohydrates risk more obesity. And there's a lot of preaching of different diets, including the Mediterranean style diet. And if we look, for example, at vegetarians, the South Asian community, certain parts are vegetarian, but often the vegetables are beaten to death, aren't they? They're heavily cooked in oil and deep fried, and so you lose all the benefits. Whereas if you look at the Mediterranean style diet, they're sort of half cooked, crunchy, and that retains nutrients and things. So it's not so much what you're eating, it's how you prepare the food as well. And I tend to tell patients, as a general rule, if it's tasty, spit it out. Yeah, because often the tasty stuff is sweet, salty, and fatty. But that's being cruel. I think the key thing is with a diet is there is no need to ban anything. You need a bit of a life. But it's all about what is a luxury. A luxury is a carrot stick. No, it's a routine is a carrot stick. A luxury is your pizza and fast food. So I think it's all about balance. And I don't know if there's other dietitians on the track as well.
Thank you, Sunny.
There's cholesterol as well. We need to make sure our blood cholesterol is well controlled. And the thing about cholesterol is people think it's linked to diet. 70% is the liver is producing. And so most patients will need what we call statins. And then finally, I suppose we can talk about physical activity. And we're moving in our profession to encouraging people to take exercise. What we're saying is 30 a day. Now that's not cigarettes, but it's 30 minutes of physical activity a day. And even if you enjoy washing the car, doing the hoovering, walking the dog, or doing Bhangra, whatever you like, if you can do 3 lots of 10 minutes, that will burn calories, is aerobic, etc. So I think that I've probably gone on a bit, Menaca, but I think that
That's
just
okay. No,
summarizes some of them.
thank you so much, because it's really important. And when you were
Yeah.
talking about waistline, I was thinking I am in denial. I most of the time I don't want to measure my waistline and I call myself a chocoholic dentist. So of course there's something for me to think about for sure. Thank you, Sadi. So stress is often discussed as a cause for many illnesses, not only heart disease, but especially heart disease. So how much evidence is there around that link between stress and heart disease?
That's a good question. And often patients will ask that. And I start by saying, well, I'm not a qualified psychiatrist. So I'm not here to diagnose stress. And the thing about stress is quite subjective, because one person's stress is another one's fun and games. So it's all relative. And the other thing is that it's relative. Now, if your house burns down, or you get the sack, or you lose your job, or bereavement, that's stress. But if you have a row with a neighbor, or you lose your car keys, that becomes stress. So I think what I tell patients is that on a day-to-day basis, we will have stress. It's all about how relevant. This week at home, our washing machine has gone. I had a nail in my tire. Our Sky is not working. And one of the gates, garden gates, is broken. So, you know what I mean? That which is stress. So it's a daily thing. But what I tend to say with cardiovascular disease is that stress is probably a cofactor that makes symptoms worse. When you're feeling low and miserable, everything becomes exaggerated. Now, there's also, you will pull up evidence that if you look at blood pressure, that there's meditation techniques, and I presume they're linked to by lowering stress. So I think it's a discussion point, but I never upgrade it to business class. I think there's more important risk factors to address and keep stress in the background.
Sure. Thank you so much, because it's very much talked about factor, stress. And I have suffered from mental health issues myself personally, and it's no secret. And even particularly amongst healthcare professionals as well, they talk about stress being a factor. And but in even healthcare professionals, ironically, there is a lot of heart diseases seen. And and mainly they then talk about stress. So that's the reason I really wanted to ask that question. So thank you so much for enlightening us. It could be, but you don't definitely put it in the top 4 or top 5. So
yeah.
So as you said, so these people are at risk. So mainly you definitely touched upon South Asians being one. We'll come back to it. But people who are at risk, how do they usually present to you?
Yes, so that's another good question. So if people are, so if we look at the coronary arteries, if we say that the heart pump has got 3 main arteries, I call it 3 motorways, the M1, the M2, and the M3. Medically, the one down the front, left anterior descending, the one down the back, the left circumflex, and the one on the right coronary. And they've got B roads, they've got other branches. Now, it's the motorways that can start to fur up over time with risk factors, the narrowing. And if they get to a critical level, it's a bit like a stone in a drain pipe. If it's a certain size and it's affecting flow, then they will get chest pain, discomfort, tightness, however they want to describe it, usually in the middle. But it can go to the arm, they can get breathless, and it's usually linked with exertion when they're carrying their shopping or going upstairs. So that's what we call angina, and that's usually a warning that something is narrow. There's a group where that starts happening at rest. They're just lying in bed, sitting on the couch. That's unstable angina. And then there's a group where it's heavy, it lasts for a fair amount of time, they're sweaty, they're breathless, and that's a feature of what we call a myocardial infarction, a heart attack. And that is a medical emergency. So there's a gradation of how people may present. There's another group which is quite interesting, where they can actually develop narrow or blocked arteries silently. They don't even know it. And this is sometimes, when you see people collapsing on a squash court, and then if they tragically pass away, when we do postmortems, we see blocked arteries. And sometimes that's because of related to people with risk factors. And diabetics, for example, may not get the typical symptoms. And this is why we try to encourage people to have health checks. Get your blood pressure checked, get your cholesterol checked. Let's look at your, waist circumference. Let's look at other aspects, and let's start thinking about easy tests, non-invasive. We can take a photograph of your arteries, a little bit of X-ray, CT coronary calcium or CT coronary angiogram. We can do an ultrasound of the heart, echocardiogram, look at the heart pump, if it's been damaged. We can do cardiac MRI, and all of these tests now are explosive in terms of numbers we're doing globally. And the beauty is many of them are non-invasive. And so I think that it's those kinds of presentations, symptoms, but also recognizing those at risk that we need to explore if there is anything early. And so, the world is divided into two. Some people say, don't fix what isn't broken, leave me alone. And there's another group that feel, why do we wait for an acute event and then start investigating and treatment? I'm more on the side of the second one, and I'd like to explore people at risk, but I can understand why others feel, when your time is up, your time is up. But it's interesting, Menaca, I remember going on the radio once, I think it was earlier this year or last year, and I was talking about the same topics, and a person came on the radio and said, Dr. Gupta, I'm fed up of listening to you, because all you say is eat this, don't eat this, walk more, stop this. He said, when your time is up, your time is up, leave us alone. So you know what I said to him? I said to him, Mr. Jones, in the year 2021, it's not easy to die. It's very difficult to die. But what is easier, if you don't take your blood pressure tablets, don't stop smoking, don't walk more, don't have your test, you'll need your leg amputated. You'll need an oxygen cylinder. You'll need your third bypass. So what we're trying to tell patients is that we're not just looking at years of life, we're looking at quality. You don't want to be ending up seeing a cardiologist often. You don't want to be ending up in A&E needing oxygen to breathe. And this is why risk factor control and treatments early prevent that. So it's an interesting idea. We would all like to go like that, but it doesn't happen. It's sadly, if you look at heart failure patients, they're people with a weak heart. Often they've had 5 admissions in the previous year in hospital, miserable. Can't breathe, can't brush their teeth, they get breathless, got leg swelling. 5 admissions before they may tragically die at the end. It's that kind of concept.
Sure. Thank you so much, Andy. It was interesting listening to you about the hidden heart disease in particular and other things, because I have special interest in this subject because I am perhaps prone to it because both my parents are cardiac patients. My mom doesn't have any family history, but however, she's diabetic, and she had bypass, so I can still kind of digest the fact because she's diabetic. My dad, as far as back I can see, even as a young child, he always did exercise. He ate, his food was very healthy. He does meditation. And I think he even went on, he is the health conscious person as much as I know in my circle from a young child, as a young child. However, he had heart disease. Perhaps it would have come early if he wasn't careful. I don't know. But so, other than the risk factor, he doesn't smoke. He does exercise. He eats healthy, and and he did have a blood pressure, but he always took his medication as being a doctor, so he was careful. So what else can it be? So I'm just baffled, because this could be me in a few years' time.
Yeah, so it's always easy when we see patients who have cigarette smoking, high blood pressure uncontrolled, they're overweight, they're diabetic, and we can always say that in terms of risk, they're much higher. But there will always be a proportion of patients where they've done everything right. Yeah, they've done everything right. But if they have the wrong genes, genetic makeup, and perhaps, in that scenario, if you look at uncles, brothers, and sisters, if they develop heart disease, there may be a gene running in the family. So I think that it is always sad when we see that scenario. But I think that there's it's a bit like what I was saying about smoking. We can scold our patients and tell them off. Why are you overweight? Why are you smoking? Why are you drinking? But if we turn it around and say, do you know that within a few days of stopping smoking, your smell will come back, your skin will feel better, you'll be able to take a big breath. And if we tell patients, if you stop smoking for a few months, you know how much money you will save. Does that make sense? And I think with the diet as well, that you can tell patients, look, there isn't any magic. It's all about input and output. And for all of us, if we go back, as the years go on, we don't actually exercise as much. We don't burn, but we still eat the same. And so that balance has gone. And I think with most things is that if events happen, like you were describing with family, that fine, it will take a while to try and work out why. But if you have a strategy and say, at least we can go forward, and this is what needs to be done. And this is something I use quite a lot with patients when they say, why did the GP miss the breast cancer? Why have I, had a heart attack? And I often say, look, whatever's happened has happened. We can't really undo that just yet. We'll deal with that later, but let's move forward. Let's have a strategy to treat the breast cancer. You're going to go to the best oncology unit and surgeon. We're going to look at your weight and diet and rehabilitate. So I think that there's ways that we should encourage positive activity and thoughts for our patients.
Sure. Thank you so much. Perhaps it's time to come for a consultation with you then in that case. So thank you so much, Sandy, for that. So if people present with all these signs and symptoms, like you said, they might not be able to brush, they might have palpitation, they might be, breathlessness. So how do you treat them? What do you do in the hospital for them, really?
Yeah, so there's different settings in terms of where we treat heart patients. So the emergencies, and we are indebted to our paramedics, who have really been heroes, not only in cardiac care, but stroke care and RTA care, and in this recent pandemic as well. And with a heart attack, for example, the patients often taken from the scene, from home or wherever where they collapse, straight into our big cardiac centers like BARTs, where we have what we call a heart attack center. The patients have basically had a heart attack, their artery is blocked, and we do a procedure called a coronary angiogram, invasive, where we go through the artery in the wrist, the radial artery on the leg, all the way under x-rays. Patients are usually sedated, and we find where the blockage of the coronary artery is, and we essentially unblock it with a wire, a biro spring, which we call a stent, and a balloon, and we use this technique to open up arteries. So that's sort of the hyperacute. And then if patients just present with what I mentioned earlier, unstable angina or a non-emergency heart attack, a minor one, where the blood test, what we call a troponin, is a special blood test that picks up heart damage, or the ECG, which is a heart trace that's done in A&E and in the paramedics. Patients are often admitted in the coronary care unit and with medication. So the medication is almost to rest the patient and rest the heart. There are things like aspirin, statins, beta blockers, ACE inhibitors, nitrates. These are various medications we have to help improve the flow, prevent clotting, get the cholesterol down, and alleviate symptoms. And again, they will move on to further treatments. In some patients, when we do the angiogram, they have 3 arteries. The 3 motorways have gone blocked or narrowed, then they will need a new set of arteries, what I call a bypass, what we call a bypass. And other patients, it just be medication. So we're very lucky in today's world in cardiology. We've got some fantastic medications to improve outcome for patients and improve symptoms as well. So what we're saying is that we've got a number of ways of detecting heart disease, non-invasive. We have invasive techniques. We have a number of medications that patients will be on. And we have these interventions, coronary stenting, bypass surgery, and for other heart disease patients, we have techniques called ablation for rhythm problems. If they have slow heart rates and collapsing, we have pacemakers, we have implantable defibrillators. So cardiology is an ever developing, ever evolving, and I think the thing about cardiology, everyone can relate to it, either a family member or themselves or the risk factor.
Sure.
But I think maybe, Menaca, it's a good time to just say that this is the hard work that the healthcare is doing. What is the deal? The deal is the patient should do the similar thing for their health. And you know, this is always a difficult one. You know, changing lifestyle and behavior is not easy, is it? But you know, I often tell my patients, you know, that aspirin a day is thinning your blood. Mm-hmm. But that cigarette a day is thickening your blood. That aspirin's not working. Sure. Yeah. So and you know, there's often these ethical debates. There was debates about if you have cigarette smokers, should they really have a bypass operation? Do they deserve it? You know, it's a bit like alcoholics, and should they have a liver transplant? Ethical debates as well. And I think we don't want to get into that aspect, but always just trying to encourage patients to tell them, you know, things that they can do to minimize risk, or if they've had an event, try and prevent the second event.
Sure. Thank you so much, because it's, you know, as dentists as well, or hygienists, we say the same thing. Is it just because they come to see you once in 6 months and we clean their teeth or fill their teeth, it doesn't mean it is I often tell my patients, it's partnership. You know, you keep your side of your agreement, and I will promise to keep my side of the agreement. You know, that's so. But it's a partnership, isn't it? Really,
partnership. But there's often the scare, you know, with heart disease is that, you know, when you've come through 999, let's say you've had the blue light, let's say you've been on the coronary care, been monitored and ward rounds. People are quite scared. They've been in the cath lab, and it's usually on that day when they survive and they're treated, they stop smoking, eat properly, and start walking more. And that's human nature. But our message is, don't wait for the event to change your life. Try to tweak earlier.
Sure. Thank you. Prevention is better than cure, isn't it? Definitely. So thank you, Sandy. So I'm just going to speak about something personal as well, because a couple of years back, I was admitted in the hospital, you know, out of the blue. I never had blood pressure. If at all, my blood pressure was always low. That was the problem. And suddenly, within like for a couple of months, perhaps that's all I ever had in my lifetime so far, high blood pressure. Suddenly I had high blood pressure. It was a stressful period in my life, I must add. But my GP said, no, you will have to go to the hospital. Doctors and being not good patients, I decided to go into work, but I couldn't. Then I had to come back home, and they did the ECG. They found something unusual. I really don't know exactly what it was, but then I was admitted in the hospital for a week, and then they decided to do angiogram, perhaps partly because my parents' family history as well, and they didn't find anything. But for me, it is really kind of mysterious. You know, I never had blood pressure, and ever since I have never had blood pressure. And suddenly at that time, obviously for them to keep, because I must have been the only patient who said, oh, just send me home, I will be okay. And the consultant came and said, the patients, we tell them to go home, they don't want to go home. The patients we want to stay back, they want to go home. So it's always a dilemma they have. So they stay. So what could be the explanation for that, Sandy?
It's difficult to know. I think that, did you recover promptly afterwards?
Yes, because of course
yeah.
they did put me on a for medication for high blood pressure for a very short time, and then I went back to my normal blood pressure, and I have never ever gone back to that ever again.
Yeah, so it's difficult, but I think that when we see patients with, say, very high blood pressure, they can present quite unwell and with a different collection of symptoms. They're just very irritable. They have neck discomfort, they have chest pain, headache, dizziness. So, and yes, if we control the blood pressure, things can improve. But I think it sounds like what they were trying to do in that week of being in hospital is the number of tests to rule out stuff.
Sure.
I think it's a bit like chest pain. You see, chest pain can be from the heart, lungs, ribs, muscle, gullet, breast. So it doesn't always mean cardiac. So it's what we call cardiac and non-cardiac. And there's so many people, sadly, out there with ongoing symptoms, and nothing was found. And I often try and feel that at least we've ruled out life-threatening things. So anything else, becomes hopefully less of a problem. But we have to put our hands up in the medical profession. We don't always find an answer. It's a bit like backache. Let's say you have backache and your spine x-ray and MRI is normal, but you still got backache. So I think these kinds of issues are not uncommon, but at least they've ruled out major things.
Sure. Thank you so much for that explanation, Sandy. At least because I was always thinking, what happened to me in that just few months in my life, and before and after, I was perfectly all right. Thank you. So there's a lot of global talk about South Asians having high risk to coronary heart disease. A lot of our audience are from that region. Indians, Pakistanis, Bangladeshis, Sri Lankans, and you touched upon that as well. So I know you have done a lot of work around this extensively. So is that true? And what is your take on it?
Sorry, what was the question? What?
The link between being South Asians and heart disease.
Oh, okay. And heart disease, yeah. So the link between ethnicity, South Asians, and heart disease has been known, I think, for 60 years. And if we start in the Indian subcontinent, and let's say proportion of people from the Indian subcontinent emigrated, data shows whether they emigrate to Toronto, Johannesburg, Kuala Lumpur, or East London, their death rate from heart disease seems to be higher, 40–50% higher than the local population. Now, it is an issue here because if you go to those countries themselves, India, Pakistan, Bangladesh, Sri Lanka, there too is high heart disease. So is it emigration that makes it worse, or is it a genetic thing? And 60 years later, there is no right answer. All we know is that this population, there is a problem. And all we know is that the genetics, one day clever doctors will deal with, but for the time being, it's the environmental things we need to focus on. So try and avoid central obesity. Do avoid cigarette smoking. Be wary, you are more at risk of diabetes, hypertension, and we need control of cholesterol. So I think that this is an ongoing issue. There is a famous study that was done in a school playground in South London. And they looked at South Asian kids, I think they were 10 to 15-year-olds, and compared them to white British kids. 10 to 15-year-olds, and they measured in the blood some markers that could predict diabetes, markers of insulin resistance. And they found in the South Asian kids, even at the early age of 10 to 15, their markers were high, which tells us the genetic risk. And the thing is that once you add on the environmental problems, which we've discussed, you make that risk higher. So I don't think we're going to resolve why, but I think we need to just focus on the things we can address aggressively.
Sure.
And, you know, if we look at when we try to predict people's risk of a future event, there's various algorithms, formulas, Q risk. We now put in ethnicity and add in a factor that takes it into account. You know, there's another issue with South Asians. They're not all one population. There are differences. Now, for example, in the UK, hardly any Sikh North Indian smoke. Whereas if you go to the Bangladeshi population, you know, 25% of Bangladeshi women in East London are chewing tobacco. And if you go to the Royal London Hospital, one of the biggest dental units, they see a lot of mouth disease, cancer and stuff related to this population. So even within the South Asian groups, there is a difference. Now, there's more smokers from the Bangladeshis and the Pakistanis, and perhaps less in the Indians and Sri Lankans, maybe. The other thing that is very important and is almost, you know, with the recent headlines of race and inequality, is that within the population, there is different levels of social class and education. And if we say that perhaps the groups that are more hard pressed, like the Bangladeshis and the Pakistanis, they may get more risk than the Indians and the Sri Lankans. And this is very important, Menaca, because one of the first questions you asked about East London. So some of the highest death rate from coronary disease is Tower Hamlets, Newham, and Waltham Forest. And that's a big population from, and the Bangladeshis are often, there's more unemployment, there's more poverty, there's more people living in one room, there's less childhood immunizations, there's less visits to the dentist, and it all merges into this thing. So social class and ethnicity sometimes is a problem to unravel.
Sure. Thank you so much. You know, I'm going to follow on with a couple of questions. But before that, I was just thinking while you were speaking about the treatment for heart disease. So you said that, you know, one of the treatments you had is because including my parents, they have had it to take the vein from somewhere else and put it. So when you say if they are atherosclerosed or blocked, don't it happen throughout the body, or is it chooses where to happen?
Yeah, that's a good question. And you know, even when we do angiograms, some people, patients have only one artery affected, others have three. And so we've not been able to work out who's going to be single, double, or triple vessel disease just by, we can get some clues. We do know that people with multiple risk factors, especially diabetes and high cholesterol, tend to have atherosclerosis, you know, more pronounced, and also multiple areas. But yes, some arteries are more affected than the others, and you know, this is ongoing interest in research actually.
Apologies, Sandy. I think there was a disturbance. I'm so sorry. Yeah. And then I think somebody was unmuted, and you know, there was a disturbance. Sorry. No. So apologies. So okay, thank you so much for that, because I always wondered, you know, like you know, how do we know? And I know that you would sometimes take the artery vein from from the leg and put it. So is that not affected? You know, it's like I was thinking always, like, you know, how can does the atherosclerosis is like chooses where to happen?
Yes, but you're right that we do see people who've had what we use the veins in the legs to bypass, this is cardiac surgery. And we also use, interestingly, an artery just behind the breastbone, the mammary artery, as a bypass. So the veins in the legs and the mammary arteries. And it's this artery, the mammary, is remarkable because there's not many kinks, it's more straight, doesn't tend to get refurrowed. We do know that the veins, after 10, 15 years, do become a little bit worn out for some patients, but even some of those can be fine. And this is also very important for patients when they come post-surgery. We need to aggressively treat with the right medications to keep their blood pressure very low, their cholesterol very low, and all their lifestyle changes and the right medications to prevent furring happening again.
Sure. Thank you so much. And it's really interesting. I never knew that it is straight. So something definitely more to learn. Or there's always learning every single day. So, what can the public do themselves? What should people be thinking about? And what is the way forward? Because, we know now what causes it and what kind of treatments are there, what you can do to them. Like people who are listening today, what can they really do?
Yeah, so I think that's another hour, isn't it, to what we have to explain.
We'll have to invite you back, Sandy.
Yeah, but I think that over the last 45 minutes, we're beginning to probably duplicate some of the same discussions, isn't it? It's the same messaging that everyone needs to examine themselves in terms of what is their weight circumference, what is their blood pressure, what is their cholesterol, what is their risk, what are the habits they need to address. I think everyone recognizes that, but it's all about putting individual personal strategies. It's a bit like a diet plan, isn't it? What is achievable, as a steady thing, and you can maintain it. And I think some of the things is this aim looking at input, output, calorie intake, and how much you're burning. I think that's quite helpful. Secondly, is this issue about the salt intake. And remember, it's not added salt. It's, let's give you an example. A bowl of cornflakes, 0.5 gram, two slices of brown bread with butter, 1 gram of salt, a tin of tuna, 2 grams, a cup of soup, 1.5 grams, 2 slices of smoked salmon, 2 grams. And you see, you're still hungry and you've already got over 7 grams there. So I think, and if you have a full pizza, you're talking 4.5 grams of salt. So I think that it's all these things. And I don't believe in banning any of these things. But if you just look, for example, at a pizza, order your pizza and take off half the cheese. Just rip it off. And what you'll find is that you still have the taste, and yet you've cut down on the fat and the salt. Okay, let's say you buy a ham salad sandwich from the supermarket. Open it up. They give you 4 slices of ham, throw 3 away. So you still have the taste and you just tweaked at the salt. Now that's just looking at the salt intake, but you can see, and there's many people on the chat who are much more, dietary efficient ways of addressing it. And the specialist chefs who cook healthy as well, what they do, they use spices rather than salt. You know what I mean? I think, or chili. I mean, everyone needs a bit of chili, but I think there are different strategies in preparation of food as well. And it's interesting that, I mentioned some of the pills that we use in heart disease. There's aspirin, statin, ACE inhibitor, beta blocker. And there was this concept of a poly pill. And this came out from Bart's, 2 professors many years ago. 1 tablet with 5 or 6 ingredients in one. Yeah. And they said, if everyone above 60 takes this poly pill, you will wipe out 80% of heart and stroke. But then the Dutch, and we know that the Dutch are some of the healthiest in the world, they came out with a paper and they looked at the food in the week, the items that we have, and they said that if you eat walnuts, green vegetable cooked Mediterranean style, garlic, oily fish, mackerel, fresh tuna, etc. Not deep fried, but steamed or grilled. Dark chocolate, lots of cocoa, high bitterness, and red wine, small amount. So think of those superfoods almost, and apparently the statistics say they have the same benefit as a poly pill. It's called the poly meal, yeah, but it's all about balance. So you don't have a whole bottle of red wine, you have a glass, but the good quality one with antioxidants. And we also know there's a lot of dietitians talk about superfoods. We know things like broccoli, walnuts, avocado, blueberries, olive oil, all these superfoods. So there's ways.
Sure.
I think the other thing is this thing about people need to burn calories. Yeah, if you're going to walk to the bus stop, don't go to the one nearest your house. Go to two later. Yeah, and do a little bit of brisk walking. So you speed up your respiration, your heart rate, and that burns as well.
Sure.
So I think that, yeah, sorry.
Thank you so much, Andy. Like I was almost hoping when you said dark chocolates, you can have as much as you want, but unfortunately, that's not the case. So I have to buy the 3 slices and just throw the 2 away and just have the 1.
Yeah. And you
So
know what they say? There's a famous quote I saw on the internet. Do you know what is the biggest room in the world? The biggest room in the world is the room for improvement.
I will remember that. I shall definitely remember that. And it's a good quote. I'm going to borrow it from you for sure. Thank you so much, Sandy. So no conversation is over unless and until we touch upon COVID, in this era today, the new normal we speak about. So is there a relevance between COVID and heart disease, and how much risk is there? And is there after effects as well when there is heart disease and COVID?
So I think COVID has become such an emotional topic, isn't it? It's for the last year and a half almost. And there's a lot of COVID experts. Yeah? Everyone has become a COVID expert. Yeah? But I think that all we can see from our experience, and we've been in the front line at one stage, 80% of our hospital, and we've got 500 beds, 400 of them were COVID patients at one time. So we're learning every day with the COVID, but what is quite clear now is that people who had underlying heart issues sadly had more events or adverse effects with COVID. Diabetics, hypertensives, people who were overweight, cigarette smokers. It was a factor in that they didn't get the mild version. And the other thing is that even with COVID, if you have, even with COVID and you're not known to have these risk factors, it was causing an inflammation or is causing an inflammation and a clotting problem. So people are having lung clots, inflammation of their heart. So it's linked in those two ways. So as with most things as well, it's like, they say for cancer, 70% of cancer is lifestyle, heavy smoking, heavy drinking, being overweight. And so I think with a lot of these conditions now, there is so much intermingling. It's difficult to separate. But, I'm being a bit flippant, that if we wipe out heart disease, what are we going to get? Cancer. If we wipe out cancer, what are we going to get? Dementia. It's almost like, how do you want to die? Yeah, but it's not as simple as that because they're all interlinked. I think that we want quality of life. It's not just duration, and this is why the interventions we do is not just treatment; it's prevention as well.
Sure. Thank you, Sandy. I know it's almost about time. And I remember Sandy asking me, is 1 hour too much? And we could speak for another half an hour easily. So,
Yeah.
as we are coming to an end, as a specialist in the field, can you share some personal tips with our audience, please? I know you have given us a lot of tips, but what would be a personal, takeaway, must remember things?
I think, Menaca, I would probably like people from today individually to self-examine their lifestyle and see where they stand in terms of personal risk, and then see what they need to do and what they need to knock on the door of a health professional for. If they've not had blood pressure, cholesterol, or sugar checks, they need to have that done. And it's now, and also these tweaks will all add up. It's a bit like a Fitbit and, your steps a day. It's quite fulfilling, isn't it, to see that you can do 5,000 and 6,000 and then do it quicker and faster. But, even if you're unfortunate enough to have risk and have an event, be positive that there are treatments available and intervention, and people can do very well, even though something may go wrong. So I like your idea about spend now on prevention rather than pay later on treatment. I think that's the other thing. I suppose another message is that you don't want to meet a cardiologist that often, is another message. And I think that what we said earlier, that we do our bit and patients should think about doing their bit. But I like to think, I've given some talks in colleges and schools, and it's quite encouraging that in the curriculum as well, the youngsters are coming through much more health conscious and telling their aunties and uncles and grandparents, etc., what they need to do as well. So I think our British health education system is trying to push that as well. And I think post-COVID as well, our government and our health service are trying to promote healthy lifestyles, and we're seeing more people in the parks and walking and stuff. So it sadly took a pandemic to address it, though, but it's hopefully going to be fast-tracked.
Thank you so much, Sandy. It was a pleasure having you. And I know why you are so popular as a speaker now, because we can sit in here to, you speak all day if we can. Thank you so much for that, all the relevant tips. And I definitely have taken a couple of things to take home. And one being also to perhaps to go to a cardiologist and actually assess my risk. Both my parents being heart patients. So thank you so much. And immense gratitude for you to agree to come and speak to our audience. And I think, thank you so much for Dr. Arulnidhi and Dr. Shantaraj, who have joined as well, who are cardiologists. I think they would like to say something. So before that, let me announce the next speaker for the next week, same time, same place. Can arthritis be cured? Dr. Navarandam, who is a senior consultant rheumatologist, would be coming and speaking to us about can arthritis be cured. So I can't hear it, as Asians, I think we definitely know at least, if not more, definitely one who suffer from arthritis. So I can't wait to listen to them. So before I go to the comments from both those cardiologists, I am going to pass it over to Dr. Kanta Niranjan to give the vote of thanks.
I hope you all have enjoyed the informative but very interesting talk today by Dr. Sandy Gupta. On behalf of Meet Menaca, I have a great honor and privilege to thank him for his valuable time. We all can imagine he is one of the cardiologists in the highest prevalence area, which is East London area, where he's a very busy person, but he agreed to come today. And really, I like to express our profound gratitude to Sandy Gupta to have given such a wonderful talk today about our heart. Especially, most of us here have survived the COVID pandemic. Now we have to worry about our heart. My message is too much of anything is good for nothing. And I really like a lot of audience are here. And I really like to thank all the audience who joined today in this Zoom from all over the world and helped to make this talk and event a reality. Without you all, we cannot have such a wonderful session. And thank you, Sandy, and thank you all the audience. Thank you.
Thank you so much, Kanta, as ever. And thank you so much for introducing me to Sandy as well. So, immense gratitude to you as well. And as Kanta said, if we don't have you, the audience, we wouldn't have a show. So thank you so much for everyone who has been here. So I think if you want to say just a quick word, Dr. Arulnidhi, if you're there.
He's from Batticaloa Teaching Hospital, Sri Lanka.
Yeah.
Hello, yeah.
Yeah.
Arulnidhi, cardiologist. Yeah.
Yeah. Good evening, and it's very nice to meet you all, and we are happy to join again across the world. Definitely, we need everybody's support for this part of the world, especially rather than a curative part. It's a prevention is very, very important in this part of the world, because compared to other part of the world, the curative or therapeutic options are very expensive, and most of the time our patients are not able to afford. So thank you for advising, and it's very interesting to know that, and we are very happy to be contact with Dr. Gupta, Sandy in the future as well, to work together to do something better to our community as well.
Thank you so much, Dr. Arulnidhi Kanagasingam. And I think Dr. Shantaraj, I think he's another consultant. Yeah. Is Dr. Shantaraj still there, Kanta?
I cannot, he was here.
Yeah, I know, I got the message, but I can't seem to find.
Okay. No,
Okay, fine. So we can always go back to him when he's there. For
Can
people
I
who are
ask one question, one important question? Since my interest in elderly care, what is the oldest patient you have intervened and made a success? People are now, everyone want to live up to 100. They're coming 99, say, Dr. Niranjan, I am going home. And they are disagreeing with do not resuscitate. Everyone want to resuscitate. What is the oldest patient you have intervened, done something and improved?
Yeah, that's a great question, Kanta. So a few years ago, I put a pacemaker. I did a pacemaker procedure in a patient who was 111. She was the second oldest female in the UK, and she lived in Chingford. And you could argue we should have left her alone. She's got to this age. But the trouble was her heart rate was so slow, she was collapsing. So it was almost just to prevent collapsing. And I nearly got into the Guinness Book of Records, Panorama, Daily Mail, because it would have been the oldest patient in the world to have got a pacemaker. But because she had Alzheimer's and no next of kin, our hospital communications team said no publicity. So I missed out on the fame.
We will make sure the next time you do that, you get the fame you deserve, Dr.
Publicity. Very good. Very, very happy to hear that.
Thank you so much.
Okay.
Thank you so much, Sandy, for that. And thank you, Kanta. So for people who are listening on live, it's that time of the day to say goodbye. Until next week to hear Dr. Navaratnam speak, can arthritis be reversed? Until then, stay safe, be happy, and keep smiling.
The question time is open. People can ask